Next question. This is from Georgina, and we basically answered that question, which was, she says that when a child is diagnosed with hyperinsulinism and they don't respond to medication, they have surgery, and if they do, they don't. That's not quite true, because if you responded to diazoxide, but you had focal disease, and you knew where the lesion was because you did a PET scan, one could argue that if you just did a partial pancreatectomy and you did it in a center that's very experienced, who has the least risks of general anesthesia and of infection, etc., that 2-week hospital stay, so if someone has focal disease, by the time you prep them for surgery, do the surgery, and get them recovered, you're talking about 10 to 14 days at the most, and many kids are out of the hospital in 7 to 10 days if the surgery is minor enough. If you're talking about that and the cost of that versus a lifetime of taking the diazoxide and the risk of hypoglycemia, I think when PET scans become more available, we'll see more people doing that. However, if you had focal or diffuse and you responded to the medicine, there is a risk of surgery, and so you could argue that the risk of the medicine is less than the risk of surgery. So again, that's one of those questions that there's no right answer to. It really comes down to what facilities you have. If you have the ability to have surgery done by an experienced surgeon in a good children's hospital, versus if you don't have that access, then staying on the medicine would be the way to go. Okay, so I get another question from an anonymous questioner, and that is, what is the lowest acceptable blood sugar there is for a child?
This is a big discussion in our private group, because some of them say 70 and some say, what, 60?
So really, I think what the question is that we should be worrying about is what level of blood sugar causes brain damage. Because that's really the issue here. Because if your blood sugar is 40 and you don't have brain damage, you got away with it. But if it's 40 and you have brain damage, you didn't get away with it. It's the same 40. So how can you say 40 is the number? So the answer is that is a very complicated question. It is very hard to find anything written about that in the literature, and here's why. The minute someone puts a number on the number of blood sugar that causes brain damage, then every child who had brain damage, who had a number under that, will sue their doctors. So the doctors do not want to put this number into the literature, because they're opening themselves up for a lawsuit. That's why the neonatologists say that the lowest acceptable blood sugar is 35, whereas the endocrinologists will say that if you are trying to make a diagnosis of hypoglycemia, the blood sugar needs to be 50 or less, but if you're treating someone with a disease that causes hypoglycemia, you need to keep the blood sugar above 70. So let's talk a little bit about why there are these differences. So the issue is, how do you get brain damage from low blood sugar? And the answer is from energy failure in the cell. So remember I talked earlier about how each cell needs energy, and that energy typically comes from ATP, and so the ATP is made one part of the cell and goes to the other part of the cell and provides it energy. So the key thing is that cells need to do certain things to stay alive. If they run out of energy, they die. So how do you make energy in the cell? Well, there are 3 ways to make energy. You can make energy from glucose, you can make energy from ketones, and you can make energy from lactate. And so it's not, the question isn't what's the lowest level of blood sugar that causes brain damage, it's what's the lowest level of blood sugar plus ketones plus lactate in combination that cause brain damage. And then you add in oxygen, because you need oxygen to make energy. So now you've got 4 things that are dependent. And so this is why babies with hyperinsulinism have so much trouble compared to other babies. Because, for example, if you have glycogen storage disease, which causes low blood sugars, it also causes high lactate levels. So these babies will walk around with blood sugars of 20, absolutely happy, talking, singing, playing on their computers, because their brain is using the lactate for fuel. If you raise that blood sugar and lower the lactate, then suddenly lower the blood sugar again, they'll have a seizure, because now they've got both the low blood sugar and the low lactate. So it comes down to all of the fuels. So that is why there is no answer to the question, what is the lowest acceptable blood sugar? If, however, we stick to hyperinsulinism, what we know is that if your blood sugar is over 70 all the time, you will never get hypoglycemic brain damage. And what we know is that if your blood sugar is under 50 a lot of the time, you're at risk of getting hypoglycemic brain damage. But you could have a 30 one day and be fine, and a 30 the next day and have a seizure. And if you have a seizure with low blood sugar, it increases your risk of brain damage. So what we say to our families is that to make a diagnosis of the cause of low blood sugar, the blood sugar needs to be 50 or less. And once you've diagnosed the cause, your goal is to keep it over 70, because if you undershoot your goal and you drop into the 60s, you're still absolutely safe, but it tells you need to change the program. Whereas if you set your goal as 50, which is the lowest acceptable number that you would want to see on a regular basis, and you go under 50, then you're into the danger zone. So our goal is for a well-treated hyperinsulinism baby and child is we want to keep that blood sugar above 70 almost all the time, and occasional dips into the 60s are okay. When you start dipping into the 50s, it means the program's not working, you have to change something. And when you're going under 50, you have to do something immediately to get that blood sugar up. And this is why people check blood sugars at home, why they have G buttons, so they can have access to immediate glucose, because if the child says, no, I don't want to drink any apple juice, you just put it through the tube. And this is why we have glucagon, because glucagon will bring that blood sugar up within 10 minutes. So if it goes down and the baby won't eat or drink, or you don't have a G button, you give the glucagon and it brings up the blood sugar. Any questions?
Yeah. This is more of like a logistic question. When you take your child's blood sugar, what's the window? I had heard that it's not really current time that's that sugar. It's almost like it was a half an hour ago that was the time. Is that accurate?
So the question is that when you do a blood sugar test, does it reflect the glucose in the blood right now, or does it reflect what it was a half an hour ago? So the answer is primarily it depends how you take it. If you do an intravenous glucose test, meaning you're in the hospital and they have an IV in or they stick a needle in your arm, that blood sugar tells you what the sugar in the glucose in the blood was the very second you took the test. If you do a finger stick blood sugar, and the fingers are warm and well perfused, meaning pink and warm, and when you press them they go white and the red comes back in again right away, that blood sugar is reflecting where you are in the last minute or so before, or really at the time. That's pretty good. If your fingers are cold, now you're talking about not getting an accurate blood test, because the blood is sitting in the fingers longer than it should, and so the cells are taking more of the sugar out, so you get an artificially low reading. So when you've got a very cold hand and it's really hard to get the blood out, you can get an artificially low reading. It doesn't mean it's really low, it can falsely read low. But really the important thing is when you use a continuous glucose sensor, and that is sensing the tissue fluid, not the blood, then there is a lag. And so there's probably a lag of, it's hard to say exactly, but probably of around 10 minutes. So if someone is on a continuous glucose sensor and that blood sugar is dropping really fast, and it was 100, then 90, then 80, then 70, then 60, you don't want to be waiting until it's 50 to do an intervention, because it's probably already 40 by the time you get it. When you see it dropping fast, you want to do an intervention when it's around 80 or 70 to stop it going down, knowing that there's a tiny bit of a lag. The second thing that's important about glucose monitoring at home is that the monitors that we have for glucose monitoring at home were designed for diabetics. They were designed to say if your blood sugar was starting to go down under 100, or if it was going over 200, 250. And so they are not really accurate. So some of you will say, why do I have to bring my child into the hospital for a tune-up? And your doctors will be saying, I need to bring you in for a tune-up, and you'll be saying, but we're doing fine, I don't need a tune-up, I don't want to come back to the hospital. And the answer is that the equipment you're using at home is not accurate enough to tell you if your baby is really having low blood sugars or not. But it's the best we've got. You remember in the old days I told you when they were treating diabetics, if the urine was sweet, you needed more insulin. If it wasn't, you were okay. Well, we've come a long way on. We don't expect you to test your baby's urine, but the blood glucose meters they're still not perfect. So they're good to about 25%. So if you have a 50 on the meter, that could be a 40 or a 60. This is another reason why we say you need to keep your blood sugar up above 70, because